Alrighty, welcome back everyone to the very last section. This isn't going to take very long. What I would like you to do now is please pause this video and get out your step-by-step instruction for doing NG tube insertion. So please, step by step, if you could get that out, go ahead and pause now. All right, so if you take a look at your learning module and your step-by-step, we're going to go through this kind of step-by-step of how you are going to put in a nasal gastric tube. So, of course, I'm not there, so the best thing I've got here is a picture up for you. The first thing after you do your skill overriders and you introduce yourself and all that other good stuff, wash your hands. Make sure that you give your patient a large basin. When you go into the CLC, you're going to see all of your NG supplies are inside of a wash basin. That is a great basin to use for patients to vomit in, because you're going to be shoving a tube up their nose, down their throat. You're going to hit their gag reflex and they may vomit. Using a small emesis basin, not a good idea. That's more of a launching pad for the emesis to come right at you. So use the great big basin. Take and put a chucks up around your patient and get out your equipment. So you're going to need a pair of clean gloves. You're going to need to use the 60 cc TUMI syringe, a cup, a straw, a pair of clean gloves, the NG tube, some lubricant, a measuring tape, some tape so that you can affix the NG tube to the end of the nose, a pen light, a tongue depressor, and a box of Kleenex isn't a bad idea either. Now, if your patient is going to be receiving tube feeding, you will also need to have a jar or a can or a bottle of the tube feeding itself. Now, please remember that a tube feeding or placing a nasogastric tube can be used for not only putting something in, but also for taking something out. So if you remember way back when we talked about perioperative nursing, we were putting NG tubes into patients at that time to suck out gastric content to allow the stomach and the intestine to rest and to heal. So let's go ahead and get started placing our NG tube. So the first thing that you're going to want to do is take your pen light. You're going to inspect the oral cavity. Make sure that there is no problems. You are going to then look inside of the patient's nose with your pen light and make sure that the nasal passage is free and clear. So occlude one side, ask them to breathe in and out. Occlude the other nair, ask them to breathe in and out. Ask them if they've ever had a deviated septum repaired. If they have a deviated septum, which side seems clearer to them, if they've ever broken their nose or had any trauma to their nasal cavity. So you're going to go ahead and use the nair that is most clear. You will then take your NG tube and you're going to measure using your NG tube. So you do not use the tape measure at this point in time. That is to measure after it has been inserted. So do not use the tape measure. You are measuring with the tube itself. So you're going to take the NG tube and go from the end of the nose to the top of the ear. So you're going to take this portion of the NG tube, the part that will go inside of them, and you're going to measure from the end of the nose to the ear, and then hold there and continue down. And if you could draw a line and have it go all the way down to the xiphoid process. That is where you are measuring. Put your finger there and wrap a piece of tape around the NG tube. So it will be somewhere in this area of the NG tube. And that is your marking. So now if your patient is going to receive tube feedings and is able to swallow, what you're going to do is you're going to tell your patient to take a small drink of water with the straw and swallow. That will help lubricate their throat a little bit. And then you want them to take a big gulp of water, but don't swallow it until you tell them to. So they're going to take a big drink of water and hold it in their mouth. At this time, what you're going to do is tell the patient to tilt their head, tilt their chin up, and you're then going to place the NG tube into the nair. And when it hits the back of their oral pharynx, you're going to feel resistance. You're going to tell them then to put their chin down to their chest and swallow. When they swallow, you're going to push. Just keep pushing really fast. Push that tube all the way in. As they continue to swallow, they're going to gag. Their eyes are going to water. It's not a nice thing, but they need it. So go ahead and push the tube all the way down so it's in their stomach, and you have that little piece of tape sitting here. Once they're done, tell them what an awesome job they did and that they can go ahead and breathe and relax. Now, sometimes what you will do is that nasal gastric tube, when it comes down, instead of it going down their throat, it will curl and come out their mouth. If that happens, pull the tube back out and try again. So now that that tube is in place, what you're going to do is you're going to measure from the end of the nose here to the end of the tube using that measuring tape. That is what you use the measuring tape for. You're going to measure in centimeters. Mark that measurement down. Go ahead and tape the tube to the nose. Taking your tape, about a 4-inch section of tape, split it almost all the way down so it looks like you have a little pair of pants. Wrap one pant leg around the tube one way, the other pant leg around the tube the other way, and then the flat where the waist of the pants would be, so your piece of tape looks like a pair of pants, where the waist would be goes around the bridge of the nose here. After the patient has had that placed, take your Toomey syringe and you are going to suck back or aspirate some of this gastric content out. Do not, I repeat, do not take and push down on that plunger. What we fill our mannequins with is a mixture of water and vinegar and food coloring. So unless you want to walk around all day looking and smelling like a green pickle, do not push down on that plunger. Simply take your Toomey syringe and just dab it on the end of your piece of lipness paper, and then hold your lipness paper up. See what your reading is. It should be somewhere between the 1 to 6 range. If you are in that range, you know you have gastric content. But you still don't know if your tube is down here, which we don't want, or sitting up here, which we don't want. So we want to make sure that we are actually in the stomach. And so then your patient will go to X-ray, and they will be able to take an X-ray and see where that is lying. When your patient comes back from X-ray, if you are giving gastric tube feeding, what you're going to do is you're going to measure from the end of the nose to the end of that tubing. Remember to place a blue cap in the end of that tubing. In a real life person, when you suck back, you've created a siphon and gastric content will continue to come out. So you need to put a little cap in there. So measure to make sure that your measurement is the same and that your tube is in the right place. Then what you will do is, using your Toomey syringe, place it on the end, hold it up into the air, clamp off the bottom by the Toomey syringe, give your bolus of tube feeding, let it go in. Make sure that you give 30 milliliters of water before. Give your tube feeding 30 milliliters of water after, and go ahead and pull, take your Toomey syringe off, and you are completed with that. Make sure that you do all your correct charting. Make sure that you've checked your tube feeding correctly in your patient record. Now, do note that one patient that you have receives a tube feeding. However, the other patient that you have is having surgery done, and so they will not be having tube feeding. They are going to be hooked up to intermittent suction. So again, what you're going to do after you've placed your tube and you have measured, your patient goes to x-ray, they come back from x-ray. What you will do then is hook them up to the suction, just like you did when you were doing trach suctioning. You're going to hook them up to the suction. There's a little adapter that you will need that goes from the end of the tube to the end of the suction, the NG tube to the end of the tube of the suction device. And you will hook them up to intermittent, not continuous, so to the left, intermittent suction. And we want to make sure that it is in the green, not the red. What you did for suctioning for trach, you make sure that it was turned all the way up to the red. You're going to make sure it's turned all the way down towards the green to about 40 psi. And it will be intermittent. Remember, we do not want the end of this tube to suction to the inside of the stomach wall and create a hickey. Or a hematoma, or start sucking in part of the stomach lining. That would not be good. And then at the end of your validation, you will be asked to DC it. Again, just pull it out in one swift movement, and you'll be all done. I'm going to now switch to TPN. So you're going to see it switch. Alrighty, let's switch gears here and let's talk a little bit about total parenteral nutrition, or TPN. TPN, you talked about a little bit in nutrition class. Basically, you have a PICC line or a central line. Remember back when we were talking about IV Part A, we talked about central lines and PICC lines. It is a large bore catheter that goes directly to the vena cava, and they will get a nutritional supplement called total parenteral nutrition. Your total parenteral nutrition should look cloudy like this. It usually comes in 2 to 3 liter bags. It's cloudy, and the cloudiness is the lipid substance that is in it. It may need to be shaken because the lipids like to stick to the plastic on the inside of these bags. It is done slowly, usually only 40 to 60 milliliters per hour. You will always, always, always use a pump. It is extremely high in glucose. So every single patient, whether they are diabetic or not, will be having their blood sugars checked because it is extremely high in glucose, and they may be on insulin because you are bypassing the gut system, so your pancreas is not going to put out insulin. Of course, because it goes directly into your vena cava, you're going to always use surgical asepsis, meaning whenever you are touching or hooking anything up, you're going to use sterile technique. It always has to stay sterile. This concludes our presentation for NG and nutrition. Thank you very much. Make sure that you watch the video and get in there and practice. And don't wait. Get this one done right away. Thank you, and I do miss you all. Bye-bye.